So now that we've seen the case, the clinical presentation of the patient, so let's treat this patient. It's going to be an Evolut Pro Plus 34. So briefly about the setup of the patient. As you can see, we have that right radial access that houses a 6 French sheath. Inside is inserted a 5 French diagnostic pigtail catheter just for the angiogram guiding the procedure. And we're going to go for an echo-guided access. If you focus just here on the groin, as you can see, I've made a small incision 1 centimeter at the skin, enlarge a little bit the subcutaneous tract. And what we're going to do, I'm going to start with injecting a couple of anesthetic drugs, and I'm going to do it just with the echo guidance. So let's apply a bit of saline solution on the skin. So the landmarks, you can see the femoral head that is nicely pointing at 6 o'clock. If I go more distal, I'm going to see the bifurcation somewhere here, but very far, and we can see exactly where is sitting the external iliac. So let me do the anesthesia. So you can see nicely the needle, and the target is going to be right here. So let me just anesthetize the adventitia just for the comfort of the patient. And this is really key just to make sure that the patient is going to stand still. So let's go now for the puncture. So it's a regular needle. And so let's nicely identify the common femoral artery on top of the femoral head. I want to make sure that I have the maximum diameter. It is the case here. So let me now look at the needle. Here it is. And so the target just on top of the femoral head, somewhere here is going to be really nice, because after that it's the it's the external iliac. So let's engage the common femoral artery. We're going to put a 6 French sheath just to dilate a bit the tract, the subcutaneous tract, and then we're going to deploy the ProGlide. Okay, let me enlarge a bit just to make sure that we have plenty of, we have a clear tunnel without tissue. So I'm going to put the ProGlide now. So it's going to be a single ProGlide procedure. And at the end, that ProGlide will be completed by an angioceal, 8 French angioceal. So the regular technique to deploy the ProGlide. So we're going to advance with the ProGlide sign pointing upwards. I'm inside, outside. Let's go inside, not too deep. And then we're going to back everything. I see a nice contact, no backflow. So let me connect a couple of times. We're going to disconnect the needles. And then a very important trick that is quite important to my mind to carry on to perform is that removing the slack. So once you've withdrawn your ProGlide with the entry part of the wire just at the skin, you just take both strings together, and then you're going to keep them parallel, connected, and you're going to pull on them just to make sure that you remove the slack that was sitting within the common femoral artery. And this is going to increase your likelihood of closure at the end. So now let's bring inside the regular O35 wire. And then this wire is going to be exchanged. It's going to be the track, the lead for a 9 French sheath. And then within that 9 French sheath, we're going to put a Lunderquist wire. And inside the Lunderquist, on top of the Lunderquist wire, we're going to bring the introducer sheath. For the procedure, it's going to be a 16 French sheath. Okay, so let's bring in the Lunderquist. Thank you. So regular Lunderquist, we use a short version, the 180 centimeter Lunderquist, just to advance the sheath. So there is no need to get inside the left ventricle. And on top of that sheath, we're going to put the 16 French sheath. Perfect. So it's a 16 French. For the other versions of the Pro Plus, 14 French sheath is enough. Okay, so here we are. Let me just flush the sheath, and then we're gonna bringing the M-Platz left one to cross the valve. Meanwhile, let's just review the angiogram, the views that we have obtained. So you could see that the valve is quite calcific. We're going to try to go for a direct IV procedure. And if needed at the end, we may have to post-dilate the valve. We're going to see how it moves. So this is the cusp overlap projection. It was predicted by the CT scan, and we can nicely see the overlapping of the left and the right cusp, even more obvious here with the non-coronary cusp being nicely isolated on the left part of the screen. And this is the free cusp projection that we have here that is going to be also useful during the deployment. Okay, so let's now proceed. So the regular technique that we're going to utilize just to cross the valve is going to be that M-Platz left one diagnostic catheter, a 5 French. You may utilize a 6 French if you want, and the technique is going to map from just below the left main in the non-coronary cusp towards in the left coronary cusp towards the non-coronary. Small trick, just to cross the valve. On the straight, just at the distal 2 centimeters of the straight wire, a 45 degrees angle, and this may be useful just to have a wider range of movement of your wire when you try to cross. A very simple trick, highly efficient, particularly in very challenging anatomies. So let's start just below the left main. Here, and we're going to really map from the left coronary sinus to the non-coronary sinus, trying to locate the orifice of the aortic valve. So if you apply that technique most of the time, from top to bottom, just below the left main, and then you rotate clockwise, pulling your M-Platz left one, that angle, it may minimize the time needed to cross. So let's record a pressure just before bringing in the Safari. And so let's record first an hemodynamic assessment. Thank you. So as you can see now, if you just focus on the hemodynamic assessment that we have a couple of very important information. So first, the heart rate is about 50 to 60. Second, we have a very high gradient with a peak-to-peak gradient close to 70 millimoles of mercury. That is quite high, related to the calcium load at the level of this valve. The aortic diastolic pressure is 45 to 46, so we have that reference for the end of the procedure. And the left ventricular end diastolic pressure is quite normal, 10. Okay, so it's time to insert the wire. The wire that we're going to use today is a Safari small curve. This is the curve, regular one that we utilize for the vast majority of our patients. That small curve most of the time accommodates most of the left ventricles. So we're gonna use it. If we see the fluoro screen, we can nicely see that we have a nice band of the M-Platz left one within the left ventricle. So we may very gently extrude the Safari wire that is going to retain the shape and then help us drive everything. So let's keep the wire where it is, and then we're gonna withdraw. We can push a bit the wire. Thank you. And do the exchange. Let's keep the wire where it is just for the final steps of the procedure. Okay, so what I propose is that we just change our gloves, and then we're going to go back for the valve deployment. So the valve is ready. We've changed our gloves. So let's move now for the withdrawal of the sheath, and then we're going to insert the delivery catheter. Okay. So let's do the exchange. Okay, so let's insert the valve. And we're gonna just make a pause once the valve is inside to just define the proper orientation of the catheter, just in relation to the commissural alignment. Okay, so just to let you know about the ACT of the patient, ACT was 260, and the heparin was provided just at the start of the procedure to the patient. Okay, so let's stop here. So if you focus just on the delivery catheter, you can see that the flush port is rotated at 3 o'clock. And this is the appropriate way to make sure that we have an appropriate, a proper commissural alignment, and putting the C-tab that is one of the commissures of the Pro Plus to superimpose it with the commissure between the left and the right coronary cusp. So 90 degrees clockwise from that flush port, we have the C-tab, and normally it should allow us to have a proper commissural alignment. So let's start with that. Before advancing, if we focus here, what I'm going to do is to prepare ourselves for the direct wire pacing. The QRS are quite narrow for this patient. So what we're going to do is one end of the crocodile clamp is going to be directly inserted, connected at the skin of the patient. Okay, so let's now proceed. Okay, we may pull a bit on the wire just to cross here. Tire le guide. And then we're going to see, okay, just if we focus, we stay here. Couple of informations. So first, we see that the pigtail is nicely sitting in the non-coronary cusp. Second, that the heart marker is really being seen center front, so the commissural alignment is appropriate. And this is defined and clearly confirmed if you watch the paddle pockets just on the upper part of the screen. You can nicely see that both paddles are located into the paddle pocket. So it means that the C-tab that is seen on top right upper part of the screen is facing the commissure between the left and the right coronary cusp. So let's take the wire, and we're going to connect it to the over part of the crocodile clamp, and this way we're going to be ready to proceed with the valve deployment. Okay, so let's start to deploy the valve. Okay, we can start to open it. So it's very important to go very, very slowly. And the first movement is for myself to slightly push on the system just to locate the stand frame that we see here below the non-coronary cusp. And that's really my target, my focus for the time being. One hand is maintaining the shift, the other hand is just extruding the catheter. So let's make a pause. We're going to record that. Okay, so it's a very high position, but the position is good. So we can continue to deploy the valve. So we're reaching the node 2, node 3, so we're going to make a pause, and we're going to fast pace at 150. Okay, pacing on, and we can continue to deploy. Okay, perfect. And we're going to decrease the fast pacing at 100 and at 40. We may expand a bit more till the black. Thank you. So what we see here is that the valve is not fully expanded. We're going to go to the LAO projection, our LAO 10 projection. That was the projection for the free cusp assessment. Let's assess everything here into that projection. The patient is really stable. There is no conduction disturbance. So we can see that related to the left coronary sinus, the depth is fine. It's below 0, it's between 0 and 5. We may slightly go upwards, but here what we can anticipate, as you can see, is a need for post-dilatation. So let's go to our cusp overlap projection and reassess everything. Reassess the depth, the real depth in that projection. Okay. So in that projection, we are like 3 millimeters below the annulus. There is no major regurgitation. There is a need for post-dilatation. So what we're going to do is potentially, if you agree, is to leave the valve where it is and to go for a post-deal with a 28 millimeter balloon. Okay, so let's deploy everything here. So for deployment, we're going to fast-paced as well at 150. So I'm just going to pull a bit on the wire, withdraw the pigtail, and we're going to fast pace at 150. Okay, so pacing on. Tu pourras faire, ouais, tu vas doucement. Okay, pacing is on. We can expand the valve. And very gently, what I'm going to do is to keep the coaxiality, but not too much, because as it's not fully deployed, I don't want to go a bit too deep. Okay, so I'm just pushing on everything. You can see the C tab. Okay, full expansion, perfect. So let's now expose the C tab, and it's just obtained by playing with the wire, and you can see that the C tab is disconnected. So let's pay attention to the nose cone, reinsert everything, and we may. Okay, so the heart rate is fine. So let's disconnect, and then we're going to recapture. Okay, and then we're going to withdraw everything, keeping the wire, and we're going to reinsert the sheath. So let's proceed for the post-dilatation. So this is a 28 millimeters nucleus balloon. So we're going to put it here. Let's connect the distal tip once again for the stimulation. So back end of the wire to the over crocodile clamp. And then we're going to inflate at 100, pacing at 180. So pacing on. Okay, pacing is on. Let's inflate. Okay, full inflation. Okay, deflation. And I like to push a little bit downwards, pacing off. Perfect. Just to make sure that we have a nice expansion of the balloon without too much foreshortening of the stand frame upwards. Okay, so let's withdraw the balloon, and then we're gonna bring a pigtail for the hemodynamic assessment, and then we're gonna assess the regurgitation that we have. So here is the hemodynamic assessment of this patient. So the heart rate is exactly in the same range as what it was before. Diastolic cardiac pressure exactly the same, 45. And diastolic LV pressure, same range, 15. And we have a nice difference between the diastolic cardiac pressure and the left ventricular and diastolic pressure. So it's from an hemodynamic standpoint, it looks good. Let's do the angiogram, and a very final important point is the narrow QRS that we have, not in favor of any risk of heavy conduction disturbance for this patient. So let's withdraw the pigtail, and we're going to do 2 root shots. The very first one in our cusp overlap projection. Okay. And what we can see here, okay, so no regurgitation first, so this was expectable with the sealing properties of the Proplus. But very importantly, if you watch the C-tab, it's almost like 5 or 10, 15 degrees difference, but it's facing the commissure between the left and the right, and we see the filling of both the left coronary artery and the right coronary artery as a second time of the angiogram. So nice depth, no regurgitation, nice commissural alignment, and we need to reassess everything into the LAO projection. It was LAO 10, so let's do that angiogram. That is going to be more interesting for the coronary arteries. So here is the final angiogram in the LAO projection, and we see the nice, a very nice feeling of the left and the right. So it's okay, and no regurgitation at all. Very impressive. So let's go for the closure now. So let me disconnect our pacing system, because as you can see, the QRS are very narrow, so not enlarged at all. So that's very important. And we're gonna leave that 035 wire inside. We're gonna close the ProGlide, the very first ProGlide, with the wire in place, and then integrate the angioseal, complete with the angioseal at the end. So I'm not pulling on the strings at the time for the time being. Okay, now I can pull, and we can withdraw the introducer. And we're gonna bring in the angioseal, because it's a very deep vessel. But here already we don't have a major bleeding as you can identify. So let me control that small bleeding before we insert the angioseal, and we're gonna see if it stops the bleeding. And let's see what we have. Here we have a very tiny residual bleeding. Okay, so what we're going to do, we're going to deploy the angioseal, because it should be fine. It's not a major bleeding. And then, if you agree, assess what we have. So let's first disconnect the angioseal. And the angioseal was deployed without any tightening of the ProGlide. So now it's the time to tighten the ProGlide. I need to find the proper tunnel. Here it is, and then I can tighten everything more appropriately. Okay, so that's nice. So let me close everything. Okay, so we don't have any bleeding at the skin, but we need to control with an echo assessment, just to control everything. Okay, so let's take the echo. Okay, and we're gonna try to identify the location of the angioseal. So here it is. It was on top of the common femoral artery, just the femoral head. We can see the track, and the angioseal is just located here. We can see the path towards the vessel. Let's put some color on top of it, a little bit higher and on the left. Okay, and here we are, just the location of the angioseal, and we don't see a little bit we don't see any bleeding. If we move upwards, up the color, tu peux remettre la couleur, et up c'est en haut. Okay, thank you. Just at the location of the angioseal, we don't see anything, so that's fine. Let's go down a bit with the color. And here we see a distal filling of the vessel. More proximal, we have nothing special, so it's fine. Okay, so here we are. 34 evolute Pro Plus, more contemporary access of the right common femoral artery with the echo guidance, even for puncture and closure. So that's it. It's time to debrief. Let's scrub out, and if you want, we're going to continue that interactive discussion. Thank you.